From beautiful Sydney, the city of Opera House, Darling Harbour, Blue Mountains, and beautiful beaches, this is ICU Primary Prepcast, a monthly podcast about physiology and pharmacology in intensive care.
Welcome to ICU Primary Prepcast.
Hi, I'm Maddie.
Hi, I'm Swapnil, and today is our second episode in the series of measurement and equipment. Today, we are going to discuss a few other specific questions which are commonly asked in primary exams. The first question is about the ABG machine, and every single ICU trainee has to understand how ABG is performed, and not just interpret values on the ABG paper, but also how those values are obtained by the ABG machine. So, Maddie, can you please describe how the values for PaO2, PaCO2, pH, and bicarbonate are determined on the blood gas sample?
So firstly, the PaO2 is measured using a Clark electrode. This consists of a silver anode, a platinum cathode, electrolyte solution, an oxygen permeable membrane, and a voltage source. The silver anode is submerged in an electrolyte solution, which is usually potassium chloride, and a voltage of about 0.6 volts is applied across the electrode. This causes the silver to react with the chloride, producing electrons. The platinum cathode then utilizes these electrons produced to interact with the oxygen from the blood gas sample, with the equation where oxygen plus 4 electrons plus 2 molecules of water make 4 hydroxyl ions. The current flow is then measured. The more oxygen available, the more electrons which can be taken up by this cathode, and the greater the current flow. The measured current flow is therefore dependent on the oxygen tension in the blood. pH is measured with a glass electrode and uses the fact that if a glass membrane separates two solutions of different hydrogen ion concentrations, a potential difference results, which is proportional to the hydrogen ion gradient between the two. A measuring silver or silver chloride electrode is encased in hydrogen-sensitive glass and contains a buffer solution which maintains a constant pH. This glass electrode is then placed in the blood sample, and hydrogen ions pass through the glass and are buffered in the measuring chamber. There is also a reference electrode which is separated from the blood sample by hydrogen permeable glass and contains potassium chloride solution with no buffering properties. Once hydrogen has equilibrated between the blood and the potassium chloride solution, the potential difference between the measuring and the reference electrodes is proportional to the hydrogen concentration. PaCO2 is measured using a Severing-House, which is a modified glass electrode. This uses the same underlying concept as the pH glass electrode. The electrode is bathed in a bicarbonate-containing solution and separated from the blood sample by a carbon dioxide permeable membrane. Carbon dioxide then diffuses from the blood sample through the carbon dioxide permeable membrane and into the bicarbonate chamber. It then reacts with water to produce hydrogen ions, and a change in pH then results. The amount of hydrogen ions produced is proportional to the PaCO2, and this is measured by the pH-sensitive glass electrode. All 3 of these electrodes must be kept at 37 degrees. Bicarbonate is the final common value, but it is not measured directly by the ABG machine, but rather is calculated. The Henderson-Hasselbalch equation uses the measured pH and PaCO2 values to calculate the bicarbonate value for the sample.
Thanks, Maddie. So all of these 3 measurements can be asked in a primary exam in a various different formats. This primary Viva, we had the question on the Clark electrode. So make sure that you understand the principles of each of these measurements, and you should be able to explain in a simple terms during your Vivas. Also, it's important to pay attention to the diagram of Clark electrode, because sometimes you might be asked to actually label the diagram of Clark electrode. So let's move on to another very commonly used measurement in ICU. And almost every patient with a shock gets this monitoring, that is arterial line. Now, can you please define and explain damping, resonance, critical damping, optimum damping, and the natural frequency for arterial pressure monitoring?
So damping is the process by which some of the energy is absorbed in an oscillating system and thus the amplitude of some of the oscillations are reduced. Damping is required in all systems, but both over and under damping can be a source of error in arterial lines. Causes of overdamping include three-way taps, bubbles, clots, vasospasm, narrow, long, or compliant tubing, or kinks within the cannula or tubing. Overdamping will result in an under-reading of the systolic blood pressure and an over-reading of the diastolic blood pressure, but with minimal change in the mean arterial pressure. Underdamping will cause a falsely elevated systolic blood pressure and lower the diastolic pressure. Critical damping is the minimum amount of damping required to prevent any overshoot. The damping coefficient in a critically damped system is 1. However, this makes the system very slow to respond to any changes. Optimum damping provides the best compromise between responsiveness speed and accuracy and occurs at a damping coefficient of about 0.64. Optimum damping can be assessed by using the fast flush test, where the system is flushed with high pressure saline, which causes oscillating waves that resonate at the natural frequency of the system. Optimal damping occurs when there is at least one, but no more than 2 oscillations following the release of the flush valve. The time between these oscillations should be less than 20 to 30 milliseconds, and the amplitude of each oscillation should be no greater than 1/3 of the previous oscillation. Natural frequency is the frequency at which a material oscillates freely. An arterial pressure waveform is made up of many different sine waves, which are determined by Fourier analysis. The arterial pressure wave consists of a fundamental wave, which is the pulse rate, and a series of harmonic waves whose frequencies are multiples of the fundamental wave frequency. Finally, resonance. So if a force with a similar frequency to the natural frequency of the system is applied to the system, it will oscillate at its maximum amplitude. This is called resonance. If the natural frequency of the arterial line system is close to the frequency of the sine waves of the arterial waveform, it will cause the system to resonate and distort the signal. This results in a widened pulse pressure and an elevated systolic blood pressure. Therefore, the arterial line system needs to have a very high natural frequency of at least 8 times the fundamental frequency, which is 8 times the heart rate of the arterial waveform. The natural frequency may be increased by reducing the length of tubing or cannula, increasing the stiffness of the cannula, increasing the diameter of the cannula or the tubing, and reducing the density of the fluid used to flush the tubing.
Thanks, Maddie. So understanding of this all terminologies is very useful because most of the times arterial line reading in a ICU is either underdamped or overdamped, and making decisions based on underdamped or overdamped trace can be erroneous. So sometimes as simple things like length of tubing can be crucial factor, or sometimes a small air bubble can lead to, again, damp trace. So troubleshooting those issues with arterial line tracing is important, and that's why understanding of these terminologies is equally important. Now, diving a bit deeper into the intra-arterial blood pressure monitoring, can you please outline the components required to measure blood pressure using intra-arterial catheter? And what are the other information that can be obtained from the arterial line trace?
So the components required to measure blood pressure from an intra-arterial catheter include an arterial cannula, connection tubing, a transducer, pressure bag, and a microprocessor, an amplifier, and a display. So the arterial cannula is usually a short 20-gauge cannula made of polyurethane or Teflon, which reduces the risk of kinking or thrombus formation. This is inserted into a peripheral artery and transmits pressure from the arterial circulation into the circuit. Connection tubing is the next component. So the cannula is connected to a fluid-filled tubing, which provides a column of non-compressible fluid between the artery and the pressure transducer. This tubing is ideally short, wide, and stiff for reasons explained earlier, and often connected to a 3-way tap to allow sampling and zeroing to occur. The tubing is usually labelled or colour-coded, which is often red, to allow for easy differentiation from venous access. The tubing is then connected to a Wheatstone bridge transducer. The arterial pressure is transmitted to a flexible diaphragm by the column of fluid in the tubing and displaces this diaphragm. The amount of displacement is measured by a strain gauge, which uses the principle that the electrical resistance of wire increases with stretch. The diaphragm is attached to these strain gauges and forms a Wheatstone bridge circuit. With movement of the diaphragm, the gauges are stretched or compressed, which alters their resistance. The circuit is constructed generally with 4 strain gauges and the diaphragm attached so that when pressure is applied, the gauges on one side are compressed, which reduces their resistance, and those on the other side are stretched, which increases their resistance. This potential difference generated between the two sides is proportional to the pressure applied, that is, the pressure within the arterial line. The transducer is then placed along the phlebostatic axis and zeroed at this point. The pressure bag is the next component, which is usually a 500 ml bag of normal saline, which is pressurized to 300 millimeters of mercury and attached to the tubing via flush system. Fluid is slowly infused at around 3 mL an hour, and a flush system allows for a high pressure flush of the fluid to maintain patency and to check the fidelity of the system. There is finally a microprocessor amplifier and a display unit. This filters, amplifies, and analyzes the pressure from the transducer and then converts it into a waveform and number, which can then be analyzed on a display monitor. Other information that can be obtained from an arterial line trace include heart rate, heart rhythm and presence of arrhythmias, the mean arterial pressure, the pulse pressure variation, which can be seen, for example, in hypovolemia or tamponade, pulses alterans, which can be seen in severe left ventricular systolic impairment, information about morphology, such as aortic stenosis, which may have a slow rise, delayed systolic peak, and a dichotic notch that is not discernible, aortic regurg, which may have a rapidly rising pressure wave, a low diastolic pressure, and 2 systolic peaks or a Bispherians wave, HOCM, which may also have a Bispherians wave with a spike and dome configuration, poor peripheral resistance, which may have a low dichotic notch, and LVOT obstruction, which may have a rapid systolic decline. Arterial line trace can also be analysed for its accuracy, such as looking for an over or underdampened trace, and can also be used for pulse contour analysis if using things like a PICO.
That's correct. And again, that's why the arterial line trace is very important to understand, because it gives us a lot of information. And also understanding the Wheatstone bridge concept is very important, especially from the primary exam point of view. And you will be expected to at least draw a diagram of Wheatstone bridge and explain the components of Wheatstone bridge in depth. So a very important question, and make sure that you practice this question both for written and Viva settings. Now, moving on from the invasive blood pressure measurement to non-invasive blood pressure measurement. Now, once upon a time when I was an intern, we never had a facility of intra-arterial cannulas or arterial pressure monitoring. So we used to do traditional blood pressure measurement using sphygmomanometer. Obviously, the things have now got much better. And now what we use is automated non-invasive blood pressure measurement using the oscillometric technique. So, Maddie, what is the mechanism of this oscillometric non-invasive blood pressure measurement? And what are the factors that affect accuracy? And also, can you please outline some of the advantages and disadvantages with this technique?
So oscillometric devices use the fact that blood flowing through an artery between systolic and diastolic pressures causes vibrations within the arterial wall, which can then be detected and transduced into electrical signals. So a cuff is placed around a patient's arm and is inflated with air until the external pressure exceeds the intra-arterial systolic pressure, and arterial flow past the cuff ceases. The cuff is then slowly deflated, and a pressure sensor inside the cuff detects arterial pulsations as oscillations. As the cuff pressure decreases, these oscillations increase in amplitude to a maximum, which is the mean arterial pressure. An algorithm is then used to calculate the systolic and the diastolic pressures, generally using a percentage of the maximum oscillation. So there are several factors that affect the accuracy, including cuff size, where the length should be about 80% of the arm circumference and the width should be 40%. Cuffs that are too large will underestimate the blood pressure, while cuffs that are too small will overestimate it. The rhythm of the patient is also important because arrhythmias can result in inaccuracy as it's more difficult to detect these oscillations. The extremes of blood pressure can also affect the accuracy, where these cuffs generally underestimate high blood pressure and overestimate low blood pressure. The state of the vessel can also cause problems with accuracy. So if there's significant arteriosclerosis, this can overestimate the blood pressure. And finally, the level of measurement is important. So the arm should be at the level of the heart. If it is significantly above the level of the heart, blood pressure will be underestimated, and if it is below, it will be overestimated. Some of the advantages of the oscillometric technique include that it is non-invasive, it does not require any calibration, it can be used at home or in outpatient settings, it is cheap, familiar, and easy to use. It measures the mean arterial pressure, which is an important surrogate of organ perfusion, and it can measure blood pressure over time and monitor trends while eliminating observer bias or errors. However, there are several disadvantages, including complications that might result, such as muscle tremors, pressure areas, pain, limb edema, or neuropraxia. It is also not continuous. It can have several inaccuracies, as we went through earlier, and it does not actually measure the diastolic or systolic blood pressure. Rather, it uses an algorithm, which is generally only known to the manufacturer and may vary with each device.
That's correct. It's one of those essential monitoring for any patient admitted to ICU to have at least a blood pressure monitoring either via non-invasive or invasive blood pressure. So moving in from blood pressure monitoring to not so commonly used, but still very essential monitoring in ICU, that is the cardiac output monitoring. Now, there are various methods of monitoring cardiac output in ICU, and which can be classified into static and dynamic. But in this episode, we are going to focus on mainly two very commonly used methods of cardiac output monitoring in ICU. The first one is about the cardiac output monitoring using the thermodilution technique. So, Maddie, can you please outline the principles and limitations of measurement of cardiac output using a thermodilution technique?
The thermodilution technique is a variation on the indicator dilution technique of cardiac output measurement, and is generally thought to be the gold standard for measurement of cardiac output. Traditionally, this technique required a pulmonary artery catheter, but this technique is also now utilized as part of the PICO system in combination with pulse contour analysis. A known volume of cold fluid with a known temperature is injected rapidly into the right atrium port of the pulmonary artery catheter. This should then result in a decrease in temperature within the pulmonary artery. The temperature of the blood is measured within the pulmonary artery by the thermistor at the end of the pulmonary artery catheter, and a temperature over time curve is produced. The area under the curve is then used to calculate the cardiac output using the modified Stewart-Hamilton equation. The change in temperature in the pulmonary artery over time should be inversely proportional to the rate of blood flow, that is the cardiac output. Thus, the mean decrease in temperature over time is inversely proportional to the cardiac output. Limitations of these technique include some of the requirements of measurement. For example, it has to be taken in end expiration and to be the average of 3 measurements, as there is natural variability in normal patients. Cardiac output can vary up to 10% with changes in respiration. Secondly, the volume of injected. Increased volume can underestimate the cardiac output, while decreased volume can overestimate it. Similarly, the speed of delivery of the injected is important. It is less reliable if the injection is performed too slowly. Also, the temperature of the injected is important. The closer the temperature is to blood, the greater scope for error. That is why cold fluid is usually used. The colder injected is more accurate, but may cause bradyarrhythmias. The position of the pulmonary artery catheter and the thermistor tip is also important. It should be in West Zone 3 for the temperature to be accurate and not have any thrombus or debris at the end. Cardiac pathology can also affect the accuracy. Tricuspid regurgitation results in retrograde flow of the injected and thus makes results inaccurate. Similarly, arrhythmias, intracardiac shunt, or low cardiac output state may cause inaccurate readings of cardiac output. Finally, there's the risk inherent of a pulmonary artery catheter, which is often required for this thermodilution technique.
That's correct. And I guess as we are using PA catheters less and less in ICU, I guess the understanding of this methodology amongst trainees is becoming concerning. So I think if you have a chance to go to either cardiothoracic theaters or the big ICUs where they operate a large volume of cardiothoracic cases, it will be good to at least learn how the PA catheters are used and how they measure cardiac output, because we don't use them nowadays quite commonly. And obviously now with the advance of echo, we do calculate cardiac output using echocardiography more often than the invasive monitoring. Now, another technique that you briefly mentioned is pulse control analysis, which is probably less invasive than PA catheter. So can you please outline the principles behind the cardiac output measurement using the pulse contour analysis?
The pulse wave contour analysis analyzes the arterial waveform and uses the principle that aortic pulse pressure is proportional to stroke volume and inversely proportional to aortic compliance. It integrates the area under the systolic part of the arterial pressure waveform, which is then assumed to be proportional to stroke volume. Cardiac output can then be calculated as it equals stroke volume multiplied by the heart rate. An example of this is the PICO system, which uses a combination of pulse wave contour analysis and calibration with thermodilution technique, as described earlier, to calculate cardiac output. However, all pulse contour analysis systems rely on an optimal arterial signal, so under or over dampened trace will affect the accuracy. Similarly, arrhythmias, aortic regurgitation, and the use of intra-aortic balloon pumps will affect the contour of the arterial waveform and thus the calculation of cardiac output.
Thanks, Maddie. And also, it's important to understand that this technique needs recalibration quite frequently. So every 6 to 12 hours, you need to recalibrate the whole monitor. And the algorithm which is fed into these monitors is based on healthy volunteer cardiac output measurements. So in kind of extreme cases where people are with extreme shock or arrhythmias, obviously this is not going to be accurate. So again, be mindful of the limitations of this technique and don't use these monitors on every single patient in ICU for cardiac output monitoring. So again, you have to choose your monitoring device, which is more appropriate for your patient. So that's the end of our today's podcast on our measurement and equipment. But before we close our podcast for today, as per the tradition, I have to face Maddie and answer, or at least attempt to answer her joke. So Maddie.
Why did the skeptic develop hypertension?
Oh, Jesus. Skeptic developing hypertension. Well, they deserve to develop hypertension because they're always worried, or they're not happy with their life in general. But because it's about measurement and monitoring, because they are primary candidates and they don't know about Clark electrode.
Oh, no. Because he took everything with a pinch of salt.
I think this was probably the most clever joke I ever had to face so far. So well done.
Oh, thanks. But also on the subject of well done, congratulations on the primary exam people who just sat.
Yeah, I must say it was a phenomenal performance, both on behalf of college and also on behalf of candidates. So there was a massive amount of efforts gone in to conduct this exam despite all the COVID-19 pandemic. And in fact, there were 86 candidates appeared for this exam because the two sittings were combined and the exam was conducted online. So again, very well done, very well conducted exam by college staff and all examiners. And also all candidates were very well prepared and the result is just phenomenal. So again, congratulations. And Maddie, there was a lot of positive feedback for you and for ICU Primary Prepcast during the exam. So I think people are enjoying this podcast, they're learning from it. So again, thanks for those who gave us feedback and please continue to share your feedback and we will continue to improve upwards and onwards.
Yeah, definitely. So thanks for listening.
Thanks for listening. So we'll be back in month's time. Till then, goodbye and have a nice time.
See you next time.